And next up, we've got Professor Enrico Coiera. And Enrico is Director for the Centre Health Informatics within the Australian Institute of Health Innovation at the University of New South Wales. And he's asking a difficult question. Can technology save us? And he's talking about the role of e-health in transforming care. Enrico.
Thank you very much. And we've had the pleasure of hearing two revolutionary minds telling us about where we think the future might go. And I'm very conscious, though, that at the end of this conference, for those of you working in clinical services, you're going to go back to a world in which the technology is probably, late 1990s. And the question is, how do we get from where we are now to these techno futures? And I believe really that it's not just about imagining the future, it's about challenging the status quo today. And in my area of e-health, we already are pretty well embedded in some very old orthodoxies that I think need to be challenged. So I thought I would do today is be a little bit heretical in my field and start to challenge some of the e-health orthodoxies. And the first one is what I would call e-health exceptionalism. The idea that technology alone is going to be transformational in healthcare. So this sacred belief that you often see in glossy magazines and reports from consultancies or in government policy documents, which says e-health is going to be the thing that transforms our health services and makes them sustainable. The profane thought really is that, e-health is great, technology is clearly part of the future, but just like any other e-health intervention that we have, it faces some huge system barriers. Anybody who has been following the history of nation-scale e-health cannot but be interested in the failures that have occurred over the last decade. So Canada has been very interesting in the sorts of scandals around their e-health implementation. For those of you here in England, the NHS has many headlines which you could pick up for MP Fit, which really didn't deliver what was expected. And I've got to tell you, back home in Australia, our story is unfolding in exactly the same way. So whatever people try to do at nation scale seems to struggle. And I think e-health is much harder than people imagined, because really it's not about the technology. E-health is a complex intervention in a complex health system, and it's very hard to get it right. Doing the same thing in two different hospitals, for example, will give you very different outcomes. What is really interesting to me is that people will say, well, look, this system worked in this primary care setting. It's now going to go national, or it's worked very well in this single hospital. Let's now scale up nationally. And to me, that gap is the same gap as from in vitro to in vivo studies. Things just don't scale easily. My own sense, as I think about what's happened over the last 10 to 15 years, is that e-health may well be one of the most complex health system interventions we try, and trying to get it to fit and work is actually very hard. And so I always go back to what I call the first law of informatics, which is don't think about the technology, but think about the problem you're trying to solve in the first place. The technology will follow. This is not a technical story, it's a socio-technical story. And as I like to say, the biggest information repository in the organisation is not in the databases, it's in the heads of the people who work in the organisation. The biggest network is not the computer network, but it's a network of conversations that happen to provide care every day. So the system is not the technology, it's the people, it's their tools and their conversations. And if you forget that, then you're always going to fail with your techno-visions. The next heresy is around patient safety, which is core to the meeting we're at here. And the sacred view in e-health is that e-health is going to make care safer. And unfortunately, the profane view says, I'm sorry, if you get it wrong, if you design systems poorly, if you don't train people, you're actually going to lead to harm. You're going to kill people, just as with any other poorly designed intervention. There's very good evidence that e-health can help improve safety and quality. We've known that for a long time. And what's really interesting, this is a lovely study which came out just last year, comparing two commercial implementations of e-prescribing systems in two different hospitals, and it showed very, very positive improvements in reductions in medication error rates, etc. So the evidence that e-health when rolled out, can improve safety and quality is there. There's no question. But there is also growing evidence that poorly implemented, it will cause harm. And we have looked now at incident reports from our own country in Australia and the US, and now we're currently looking at NHS incidents. And it's very clear that there are very, very many examples of where e-health is associated in the root cause of harm and death of patients. So 10, 15 years ago, it was all about how e-health was going to improve safety. Just last year, the Institute of Medicine in the US published this report really saying, look, we have to be very careful now. It's time for us to start to pay attention to the harms associated with e-health. It's not that we don't want to do it. Like any intervention, there will be side effects, but we need to be very cautious. We need to measure, monitor, and intervene. So I like to say that we're actually in a dangerous decade in terms of e-health, because we don't really understand the safety profile of the technology, and yet we are, in many countries, implementing e-health at a scale never done before. And just by simple probability alone, if there's a finite chance of harm with implementing a system, then the more implementations there are, then the harm rates will increase. So what we are seeing is what we actually expected, which is growing rates of reports of harm associated with poorly implemented systems. Which leads me to the third heresy, really, which is around implementation. And this is a view which you tend to see in large government e-health organisations or hospitals, which is that e-health is a linear thing. We've got to do it piece by piece. We've got to be very programmatic. We've got to pick the standards first, then we've got to put in the foundations, and eventually we'll come and give you the clinical systems that you want. I've just recently reviewed a hospital where they put in the most trivial electronic record system, assuming that it would deliver benefit, and in fact it hasn't. The heretical view that says this is all nonsense, and that really the idea of foundations in e-health is illusory. Well, what do I mean by that? This is what I call the holy pyramid of delayed gratification, and certainly most governments will say this is the way we should do it. We should put some standards in first, then we'll eventually roll out electronic records, then there might be some basic clinical applications, and eventually there'll be some decision support systems which will give you the sorts of things that in fact we were hearing about just before. That will come with time. Just wait. Unfortunately, that's not the way technology works anymore. You know, with the cloud, with the idea of applications living in a different place, there is no need anymore to think about foundations in that way. Everything can happen in parallel. There's no reason not to have a decision support system today just because it doesn't have full access to the electronic record. It will still deliver benefit. These slides come from our National eHealth Transition Authority, which did some modelling on the benefits of a national eHealth system. And you'll see the little chart on the far left, which shows a little blue line and very little benefit in the first few years, lots of investment, little return. Then after 10 years, huge projected return, nearly all of it from, not the lower layers, but from decision support, from the tools that help you as a clinician decide and to work with the patient what the right thing to do is. So delay is not a good idea. All right. The next sacred notion is around privacy. And I have to say that this is a view I hold because I come from a certain generation, which is that my medical information is private. I don't want it to be seen by somebody else. I don't wish it to be shared publicly. I will share it with the people who are caring for me. There's a profane view which is growing, which is that I really don't care who sees my data, and I'm just going to stick it on the web because it's going to benefit me. And this has been really driven by the big changes in the way people use technology, social media, the things that people are happy to put out in the public space using Facebook or Twitter never ceases to amaze me. Facebook, as you know now, has about 2% of the planet on Facebook, you know, more than 1 billion people sharing in public all sorts of things. And these are just two of many systems, and we just heard now about Patients Like Me, which I think is just a fantastic idea and something that's growing. And what I think is interesting with Patients Like Me, and this is just a screenshot here, is that Here are people who are self-identifying as bipolar, are happy to put their names there and are happy to share their data. So rather than saying, I want all my medical records to be securely protected with lots of layers, some people are saying really that is the old world and I will benefit in the sharing. So I suspect that this is a generational view, that people who in their 20s and 30s have just a very different approach to what data is all about. And I suspect that my view is very Victorian, and I'm that person in the bathing machine in the bloomers. But I think the views around privacy that we have today in 2050 will be seen as very archaic. So the fifth heresy is around the electronic health record, and which is that e-health is all about data, and it's all about the electronic record. And this is something I see in every state or national strategy. Let's roll out that electronic record because it will deliver the benefit. The profane view that says is e-health is about services. It's not about the data. The data certainly drives the services. Data does nothing on its own. And it's not surprising then that some very large forays into e-health, so Google Health or Microsoft Vault, for example, very big corporate attempts to try and move into the medical record space have not succeeded because they were just about the data and not about the services on top, not about being able to deliver something of value. So some people will say, well, maybe what are you talking about? Are you talking about a world where everything is driven by apps now? This is no longer about old-fashioned technology. Can there really be an app for all the ills that ail us? And I think certainly that's the way it's going, but I think the notion of singular little apps, micro apps that do different things, is not the way forward, because healthcare is a complex ecosystem. Everything depends on everything else, and if you're interested in a world where you have small modules which support different aspects of care, they record your heart rate, they might capture your diabetic data, they might be capturing your schedule for your IVF. They all still need to connect together in some way. Data needs to be shared, knowledge needs to be shared. And so I'm not alone in people wondering what a Facebook for health might look like. What would it be when we can start to integrate all these things in these much larger systems? In patients like me, which we've just heard about, we have the beginnings of the sort of system where people are able to interact and share information. So we've built a system called Healthy.me, which really we build as a Facebook for healthcare when we started, but I now really think of it more like in my internet banking account for healthcare. It's the place where I store my data, it's the place where I carry out transactions, I book, I communicate with my clinicians, and where we share care pathways, as well as having a social layer around that where people are able to communicate with each other about their particular journeys. And we've now done a number of RCTs and trials of this, and I have to say it is making a difference. So the first RCT we did, which was published last year, looked at the area of prevention, being able to get people to vaccinate for flu, and you can see from the results here that we doubled the vaccination rates in the intervention arm. And we ran another trial in mental health focusing on anxiety and depression in young adults, and you can see we increased the rates of help seeking. What was really interesting to me, going back to the notion of privacy, was in the forums associated with the mental health area, we found people declaring in public suicidal intent. And so because it was a monitored forum, the mental health team was able to go and identify that individual and intervene. So I've got to say, we, as the builders of the system, were very surprised to see young adults behave in a very different way about their health in this social space. And as the slide says here, we've got other trials happening in areas like asthma and post-radiation breast cancer. So other people are working in this space, and it's very exciting to start to imagine what are the elements of this new world that will start to affect the way we deliver care. The last heresy I call information apoptosis or apoptosis. And this comes from what I find everywhere I see when we see health, which is a myriad of new and old systems all connected together. And when a new system comes in, say in a hospital, people will say, well, we've got these old systems, we need to keep them here just because they have old data, or we just like to keep this department happy despite the fact that we have a new system coming in. And unfortunately, keeping old systems adds to complexity and makes things harder and harder. And it's very hard to get people to get their head around how you would retire in a programmatic way information systems. So we tend to be accreting them everywhere. And this, in fact, is something that's not just unique to e-health. We find it everywhere. It's in the safety and quality agenda. We've known for a long time about the causes of iatrogenic harm. We have really not managed to shift, despite huge efforts, a lot of the harm rates. There's a lot of inertia in the system. The same with evidence-based practice and variation in care. Lots of effort over the last decade or so to get people to be evidence-based, and still, when we measure a variation in care, we see many people not being evidence-based. Again, inertia. If you're interested in the topic, the notion of clinical inertia is well studied, and it's the reluctance of clinicians to change what they're doing despite the evidence. And so I think when we look at what are the causes of inertia, one of the big explanations is complexity of systems, that people have too many things to do and therefore are unlikely to adopt the new. You have to create space for innovation. You have to let go. And the reason I use the word apoptosis is because in biology we manage complexity very well, because we have the notion of cell death, programmatic cell death, that from tadpole to frog, not just new structures have to emerge, but old structures have to be retired. When you create a limb, when you create fingers, the space between the fingers have to all die to allow the fingers to emerge. So biology has worked out ways of restructuring through complexity to allow us to let go of things that are no longer of value. But the idea of programmatic retirement in healthcare is something that we still don't understand. So the next time you're involved in designing a form or a computer screen, don't just ask, what data do I need added to the screen? Ask yourself, what's going to go? What am I going to let go? If you're going to design, if you're an IT type, a new part of the infrastructure for your organization, don't just add complexity, remove complexity. And as I say, when you think about the design of computer systems, I think of the endless requests people have for change and new functionality. It's always great to say we want more, but that adds complexity. Something has to go. So, information apoptosis. So I'm going to summarize. Can e-health save us? I think technology is tremendously powerful, but we have to really let go of some very, very sacred but not necessarily helpful views. E-health is no more special than anything else. It has no special status in our arm of interventions we have in healthcare. We should use it wisely but not have exceptional hope. Patient safety. E-health, again, a fantastic tool for reducing error, reducing harm, but if you get it wrong, you're as likely to introduce harm. Do not let the technologists tell you that you can't have the tools you need to make your clinical decisions today. Do not delay, because we need to go step by step. Privacy. The efforts that governments go to protecting privacy in terms of legislation and consent is tremendous. I know in my own country the big victory over the last 3 years has been the passage of laws around protection of medical records online. And yet, as I say, I suspect that will all be quite redundant in the next decade. The electronic record, as I've said, does nothing on its own. It's just a record. It's what you do on top of it. It's the tools you use to make decisions that are transformative. So if you think that implementing a record is going to change your clinical practice, you're not going to get anywhere, unfortunately, and the evidence supports that. And finally, let's not add complexity to complexity. If you really want revolution, if you want to change the way we do things, we have to make big decisions about what we stop and what we retire. So I'll finish by saying that a little heresy is good for us all. Thank you.
And thank you, Enrico. We've had 3 fantastic presentations, and while we've been having fun, we've had 2 people in the corner who've been doing lots of hard work, and I'd like to introduce our 2 information DJs who have been in this session, and if you guys want to go to the podium. we've had loads of questions through Twitter. I've been following Twitter on my phone and quite overwhelmed by the number of questions and comments we've had. Can I ask you guys to first introduce yourselves, if that's all right?
You should be on. Hello, my name's Harriet Daltrey. I'm an F2.
And my name's Joseph Ward. I'm a core surgical trainee in the Wales Deanery.
Fantastic. So, Joe, I want you to give us a bit of a summary of what we've been having through Twitter over the last hour or so.
Okay, fine. I've been looking at the themes, and really for the first presentation, I'm looking at crowdsourcing, crowdsourcing in health. Really, the idea about the first follower transforming the lone nut into a leader kind of really hit home on Twitter. How we need more first nuts and more first followers in quality improvement. Also the idea around patient involvement and the importance of patients being involved in quality improvement, and the fact there are very few patients here today really did hit home, and quite a lot of people thinking about that. When it came to the second presentation, empowering patients through technology, the fact that patients are the window into the soul of healthcare, and that they hold the answers with websites like patientslikeme.com really got people going and got people thinking. And then finally, for the last presentation about the concept of the Facebook for health, again there was some thoughtful comments on Twitter, but really the questions about privacy, security and consent came up.
Brilliant. So we've got about 15 minutes for some questions, and we've got some questions through Twitter, which I think we'll take first of all.
Okay. So from the first presentation, there were quite a few questions that came up. The first one, does crowdsourcing reduce the need for experts, and how can we be sure the public would make the right choices?
Lucian.
I have a bit of a problem to understand the question due to the echo.
So maybe we can just repeat it to Lucian. So it's a question about
crowdsourcing, and does crowdsourcing reduce the need for experts, and how can we be sure that the public would make the right choices?
Okay, thank you. Well, I don't think that it reduced the need of experts. Actually, it increases the need for it. It's based on co-creation more than just asking, and you collaborate a lot more with patients or the public. That creates also new questions for it. It's a bit like all the other expertise systems that you get more and better data in it and more understanding to it. So I do still think that experts are needed for that.
Great.
Thank you. By using technology, might this create inequalities for those without access or accessibility?
So that was a question about, just to repeat it for us close by, was about whether technology creates inequalities for people who have it and don't.
You know, I love this question because I got a company with 55 people in it trying to figure out how to measure all the healthcare, and people say, well, you haven't addressed this particular segment of the market, and we haven't. We're very focused on a particular group of empowered people that we think can be leveraged. I think that the thing about healthcare is that it's a very complex series of overlapping businesses that each have their own different engagement, information, and other needs. And the principles that that are evidenced in engaging a population are appropriate for all of those, but the mechanism, whether it be through the internet or self-empowerment or through technology that's delivered at a more effective point of care or ethnography or marketing in that context is right. But I think we also have to acknowledge that there are gross inequalities in healthcare now. Information transparency will to some degree level those, but it will also to some degree amplify those. And I think that I sometimes ask if the preservation of inequality requires that we hurt all people equally as opposed to allowing some people to prevent harm to themselves, I'm not sure that's an equality I want to work on.
Great.
Another question, will crowdsourcing work for people with rare and orphan diseases?
Will work, with rare or what?
Rare or orphan.
So, I think that going back to this question about the value of crowdsourcing, I think that particularly for rare, or I like to think of them as ambiguous diseases, healthcare there are a class of disorders where we really do not know much about the patient experience or what it's like to live with a condition or how the condition expresses itself in someone's life. And the system is terrible at recording data on that. So while it's incredibly good at measuring ejection fraction and complicated things related to heart health, knowing what someone's depression looks like or their pain looks like is sort of terrible. And then I think the very rare orphan diseases, because of the diversity of the population, they have to be done through a centralized system. So I think that it's actually the ambiguous, significant conditions, and then the rare diseases are where this is going to be the most impact. And those are the two with the greatest information deficit in healthcare. So there's a lot of alignment around those particular problems.
Yep.
And then, what of patients' reluctance to share personal data?
Maybe Enrico,
What's the question?
what are concerns about patients' reluctance to share data and what that impact might be?
Yeah, so my sense really is that we're in a transitional period, and that I'm seeing, as I said, I feel I'm from a generation where there's a huge requirement to keep my information private, and I know that my son will be living in a different world. So I think it's very important that we're just not too black and white about what privacy is going to be and how we should protect it. And government especially, I think, is really stuck because it's got to work with the people who are the privacy advocates, who really are driving it. And yet, as you see with people who work on your system, they've got a very different view.
Well, I think actually there's an important framework about privacy that we should talk about. I mean, privacy is a fundamental right. I mean, no one should compel you to give up information about yourself that could hurt you. But it's also not a moral objective. So you can have something that is both a right and is not actually moral in its pursuit. And so, I think that if you substitute the word secrecy for privacy, and they're fundamentally very similar things, would you hold secret information that would help someone else? Is a question that can be asked. It's a legitimate social question. And I think that it is possible, my sense is that people in societies would like to contribute to making their society better, sharing their data in ways that society supports with effective legislation around discrimination or other rules is a moral pursuit. And so I'd like to see the privacy debate switch from being privacy is used to protect people to anti-discrimination approaches are used to protect people such that sharing is not harmful. And I think that that's I think Europe particularly is stuck in a historical model that is going to harm it in this moment in time. The United States doesn't really have that many rules at all, and the rest of the world is operating sort of under compulsion systems. So I think that there's a real question there, which is what is the soul of a healthy society? Is it one that holds secret shared knowledge and prevents shared learning, or one that encourages that while respecting individual privacy? And I think Europe is struggling with this choice right now.
Well, one of the things I wondered about was that do social networks, does Twitter, does Facebook change that? Does it change how people are communicating things that previously they kept private? And I just come back to Lucian that 2 weeks ago I emailed Lucian to talk about this presentation today, and I got an email back saying I don't take email anymore and only use LinkedIn and other things. And I'm just wondering how social networks are perhaps affecting how much people put in the public domain about what was previously seen as private life.
Well, just reflecting to the last speaker, I think that the best apps Silicon Valley recently made for healthcare are social networks, actually. Since people are looking information into these social networks, debate on it, finding information of it, they are using actually Twitter, for instance, to create groups and talk about how to cope with this disease. So I think that social networks in many ways leverage better healthcare, also prevention. And I myself already for the last 3 years, I bought this weighing scale for 100 euros and I hop on it every morning, and about 10,000 followers get my weight and tell me you should take a light lunch, so I did. It also is a possibility to create peer pressure in a way that in close communities, for people who want to stop smoking, for instance, or do something about their weight, also social medias can leverage that as well.
Should we take another question if we've got any more?
Yeah, there was one following from the previous question saying that can we trust data from self-selecting groups?
Can we trust data from self-selecting groups?
All data whether it be a clinical trial, which is run on generally upper-class populations attending academic medical centers without comorbidities, or people that join a social network that have their own health activation components, have massive amounts of bias in them. And I think that medicine has not been very good. I mean, one of the things that I find interesting about medicine is that it's very hostile to new methodologies and uncritical of these existing ones. And what I would like to see is an overall rigorous analysis of the bias of all kinds of evidence on all sources and understanding that. And I think that look, I mean, would I trust a patient to report a lab value? No, I'd rather have the lab value directly. Would I trust a clinician to report a patient's pain level? Well, that's been studied, and the answer is the physicians underreport the pain levels by about 50% based on rigorous, components. So I think that we have to think about healthcare as being a series of sensors. Some of those sensors are instruments that are used by people to ask questions in psychometrically rigorous ways. Some of those sensors are biochemical, some of those sensors are imaging. Some of those sensors are trained clinicians assessing specific signs or symptoms that require training. And each sensor should be evaluated for its strengths and weaknesses, and like any part of a good information system, be judged and held accountable, which I think is one of the other real gaps in medicine, which is, I think that the symptoms that I went through at the beginning of my talk are medicine's unwillingness to have the uncomfortable conversations about its own issues and gaps. And I understand how difficult it is to practice with a level of uncertainty that implies when you go and look at that. But without that deep, honest conversation, or I think what's going to really happen is the patients forcing that conversation into the system, we won't see change or accomplishment. And your point about the 1999 medical errors rate, I mean, again, we've been killing 100,000 people in the United States now for 13 years per year. It's a fair amount of people, 1.3 million. At some point, they might get upset and start to complain about it and hold the system accountable, and we need to give them the tools to do so, and that will force some difficult, complicated conversations. And that will be what drives that understanding of bias and evidence and truth in data.
Yeah. Well, just any data source, as long as it's not noise, carries signal. And I just think self-reported data is data you never had before, and it's going to carry information that's of value. As long as you understand the biases in that, and then you can match it up with other data, use it. For goodness sake, why would you not use it?
Yeah.
Great. One more question?
One final question just about crowdsourcing was how robust is it as a tool? What would happen if a clinical incident, some adverse event happened because of the use of such systems?
So how robust is crowdsourcing as a tool, and what would happen if a clinical incident occurred as a result of it?
Wikipedia is a great way to look at this. And I think that crowdsourcing is somewhat misunderstood. I mean, we have a crowdsourcing society now. We take all of our youth, we put them in schools, we educate them, we find out their focus areas, we specialize them, we train them in postdoctoral solutions, and then we have them collaborate through crowdsourcing things in journals like the BMJ to produce definitive knowledge. The currency of that is a combination of merit and training. What crowdsourcing does is it dismisses the training and makes the discussion about merit alone. And I think the people that have spent their lives in training, the initial defense is to say, there's no way you will replace my 15 years of clinical experience in this particular problem. And the answer is no individual probably can. But it turns out mathematically, and if you look at Wikipedia, it has a far lower error rate than the final versions of Encyclopedia Britannica did, and is continually updated and much broader and much more powerful. And so, the point that you made about experts being more necessary, I actually think that their role will change. I think that we are moving much more to a less prestige-driven truth standard to a more meritocracy-driven truth standard, where increasingly effective analysis of data and evidence will produce better and better truths. And the role of being an expert in that point in time will be more to how to help someone navigate that information space more effectively, rather than being the definitive generator of it. And a real consequence is going to be an erosion of the brands that we traditionally consider to be most important. And I'm a graduate of MIT, which is one of the better academic brands in the United States. But in a world where you are evaluated for the level of your contribution without respect for your training or history, the youth today don't value these brands in the way that we do. And that will change dramatically. And I think the consequences for that in medicine are going to be the development of new brands, new opportunities, new centralizations that will move away from the individual expert to combine systems that leverage that to advance individual good in new ways. It will be very disruptive and kind of fun to watch.
Anything else you want to add?
Well, the only thing I would like to add to that is that we at present do not have the slightest idea of what the impact actually will be for healthcare. And the only way to figure it out is to start doing it in controlled environments, by research, small projects, scale them up, and get acquainted to it. Since just like the internet and just like social media, a lot of people still think that this will go away. It won't. Yeah. Crowdsourcing won't go away. It will stay.
I think there's a point there that should be added too, which is that people are worried about the harm of these systems, and there's been a fair amount of study about the harm of bulletin boards or internet sharing of information, and essentially, I think there's one known example of measured direct actual adverse event from the use of information from the internet that caused harm in a patient. It was someone that didn't go to an ER that should have, based on data they read that was wrong. And there's been a lot of studies, and I think the answer is that the evidence at this point in time is overwhelmingly that this is a benefit worth the risk, that the harm level is close to zero, and the benefits are potentially significant and are measured to be meaningful. And so, the original principle of caution is actually, I think, been at this point in time by the evidence weight been disproven. It's time to move forward.
Great. And I've got one final question for Jimmy. So, coming from your background, which wasn't in healthcare, it'd be interesting to find out how much you think that was influential in coming up with patients like me. A lot of us in healthcare, we've got lectures this week from Qantas, from the airline industry, from customer service in supermarkets. Coming from outside healthcare, do you think that had an impact in what you were able to do in this space?
I do. I actually, though, there's a couple of principles of engineering that come from the way we approach data and its specificity and its certainty that I think really are needed here. I mean, engineers really like numbers. We don't like poetry, and unfortunately, medicine is a lot of poetry. Some of it's very beautiful poetry, but it's a lot of description. And when you want to understand something, I think Lord Kelvin, who is one of the engineers' great heroes, he said, when you can measure something, when you can put a number to it, then you actually know something. But if you cannot, your knowledge is of a meager and unsatisfactory kind. And I would say that is a very accurate description of our understanding of medical information. It is meager and unsatisfactory, and I think we need to quantify it. But I will say a different thing. I think that the most misunderstood component about our company, about patients like me, is, what I'm really passionate about is discovery. And I'm really passionate about discovering new things that will make new differences. And the company itself is not so much a healthcare company as much as it's a discovery company. And I think the question is, if healthcare is going to be what it needs to be, the bigger question is does healthcare want to be us attempting to do what we believe to be true based on evidence that we know is substandard? Or should it become more like other industries where we measure what we do so that we continually learn what actually works and make it better? And I think that's the biggest cultural shift, and that is where you really need to bring in experts from outside, because that is not the training or the opportunity or the way we think about providing or operating healthcare, and that's the big shift. The person that figures that out is going to make the systems transform and improve the human condition in a way that we cannot imagine. And I think this century is going to be a discovery healthcare century if we figure that out.
Thank you. Well, the bad news is, unfortunately, we're out of time. But I'd ask you to give one final show of appreciation to our three speakers and our information details.